it's being streamed downstairs, and we're up roasting. Ready? We're going to continue our program, and we're going to talk about lupus nephritis. And it's my pleasure. I've not met Dr. Mathias before, and we're real excited. So Dr. Lauren Mathias is going to present to us. And she's wow, we've been busy here, haven't we? She's a board-certified rheumatologist in the Division of Rheumatology at the University Hospitals of Cleveland. She completed her undergraduate education at the University of Pennsylvania and her medical education at the University of Oklahoma College of Medicine. She went on to complete her residency in internal medicine and her fellowship in rheumatology at the University of Southern California. Wow, USC Medical Center. She enjoys connecting with rheumatology patients and finds great fulfillment in minimizing potential debilitating issues, conditions, so that her patients can continue to have full lives. And we're so grateful for that. Thank you.
Hi, I'm Dr. Lauren Mathias. I'm going to speak about lupus nephritis today. My son is here as well, and he has a lot to say about lupus nephritis, but he didn't go to medical school, he didn't go to residency, he didn't do fellowship, so if he starts talking too much, my husband will be taking him out. So today, we just listened to Dr. Warren speak about lupus, and I'm going to speak about one of the organ manifestations of lupus today, called lupus nephritis. I'm going to go over an overview of lupus nephritis. I'm going to talk about epidemiology, who gets it, symptoms, diagnosis, and treatment. So let's go ahead and just talk about normal kidneys, first of all. So here's just a diagram of our kidneys. They lead to our bladder, and then out through our bladder, we urinate. Some of the functions of kidneys are that they filter waste and water, they balance salts and minerals. The kidneys actually help control our blood pressure, and they also help keep our bones strong. So very, very important organs. In lupus nephritis, the immune system actually attacks the kidneys, and it can occur in up to 60% of all lupus patients. Essentially, in lupus, Dr. Warren alluded to this earlier, our body creates abnormal proteins called antibodies that attack our normal proteins. Sometimes these antibodies and normal proteins come together and deposit in the kidneys and cause damage. That is lupus nephritis. So who gets lupus nephritis? Typically, patients are younger, although certainly this is not a rule. As Dr. Warren spoke about, there is a higher ratio of females to males, around 9-1. It is more common and more severe in African Americans and Hispanics. It's also more common in Asian populations. And so, 30 to 40% of lupus nephritis patients will have it when they're diagnosed with lupus. The rest of them develop it throughout the course. So later, they're diagnosed with lupus, and then, years later, they may actually develop the complication of nephritis. So I want to go back to my slide about what the normal kidneys do and how important they are. Like we discussed, they filter water, they get rid of waste, they balance electrolytes, they control our blood pressure, they keep our bones strong. So it's definitely a problem when lupus damages them. So rather than filtering water, patients can get fluid overload. Rather than getting rid of waste, there can be buildup of waste. Rather than balancing salts and minerals, patients can get electrolyte imbalances, which are important because they can lead to, patients feeling confused or patients getting irregular heart rate. Since the kidneys don't do as good a job of controlling blood pressure when lupus is damaging them, patients can get hypertension. And since the kidneys help keep our bones strong, over time, patients can also get bone disease and weak bones. here's a picture of what fluid overload might look like in patients with lupus nephritis. This is something called pitting edema. Essentially, fluid accumulates in your legs, and if you touch it, you can leave a pit, and that often happens in our patients with nephritis. So how do we diagnose lupus nephritis? So of course, in rheumatology and probably most of medicine, always history and physical exam is the most important thing. So, regardless of what history the patient has or what labs they come in with or what imaging they come in with, the first thing I really want to do is hear their story and then examine them. Then we get some blood work and some urine studies. And then lastly, if we suspect lupus nephritis, really the gold standard and what's needed is a renal biopsy. Exactly, yeah.
Perfect timing.
Yes. So, this is a diagram of a renal biopsy. Perhaps some of the patient, if any of you guys have nephritis, you've had this done before. So typically a patient might be admitted overnight for monitoring. The patient lays on their belly, and either a radiologist or a nephrologist uses an ultrasound or some other sort of image guidance to find the kidney. Then a small needle is stuck into the back and a tiny piece of kidney tissue is taken out. Doctors then examine the kidney tissue underneath the microscope, and they can tell you based off of that whether or not you do indeed have lupus in your kidneys, and they can also tell you the severity of it. This is very important because I have seen patients with lupus who have kidney disease, who I get a biopsy on, and the kidney disease was not related to the lupus, and that completely changes therapy. So I really say before a patient is treated for lupus nephritis, they really do warrant a biopsy. Okay. Early diagnosis and aggressive initial treatment is very important to prevent damage. About 10 to 20% of lupus nephritis patients can progress onto renal failure or dialysis. So we really do want to treat it immediately, nip the inflammation in the bud if we can. So how do we treat it? I'm just going to go through broad strokes here. If anyone has questions about the nitty-gritty, please feel free to ask. But the mainstay of treatment is steroids and other immunosuppressive drugs. We start right off the bat, typically with high-dose steroids because steroids work immediately. And then we add on other immunosuppressive drugs, sometimes oral, sometimes IV. And those typically take a little bit longer to work. So the steroids help treat the initial inflammation while the other immunosuppressive drugs are building up. Over the course of a few months, we try to taper patients off of steroids due to their, various negative side effects, and then build up the other immunosuppressive drugs kind of to a steady state. The goal is to get the patient into remission as soon as possible, ideally within 3 to 6 months. And then we typically just watch the patient, and we do not try to take away medications for at least a few years. If a patient's lupus nephritis has been in remission for a few years, then I start slowly tapering away their medication. Okay. Other than steroids and immunosuppressive drugs, supportive measures are very important. Already, the lupus is damaging the kidneys, so we want patients to do whatever they can from the non-lupus perspective to keep their kidneys as healthy as possible. So salt restriction is important because too much salt can worsen kidney disease. Hypertension control is very important. So it's going to be hard for patients with lupus, or I won't say hard, but not that easy to manage their hypertension because their kidneys aren't working that well, but they need to be aggressive about getting the hypertension under control because it can be a vicious feedback cycle where even though kidney disease causes hypertension, uncontrolled hypertension worsens kidney disease. Management of cholesterol is also very important. If transplant is needed, that is something that can be done. But of course, we like to save the original kidneys, and we hope that we don't have to get to this step. This is a picture of, Selena Gomez. As many of you know, in 2017, she did lose her kidneys to lupus, and, she was lucky enough to be able to receive a transplant from her friend. So this transplant occurred in 2017. Excitingly, since then, in 2020, 2021, we have a couple new FDA-approved lupus nephritis drugs. So the future is even brighter right now than it was for Selena back in 2017. I do want to talk about preventative health because preventative health is important for everybody, but I would say it's especially important for patients with lupus. Because the disease in and of itself predisposes you to infection, and to add fuel to the fire, your rheumatologist is giving you steroids and drugs that further predispose you to infection. It really is important that you stay up to date with your vaccines. And in fact, there are different vaccine recommendations for immunocompromised patients than there are for normal patients. So one example is typically around the age of 65, most regular adults get the pneumonia vaccine. If you're immunocompromised, you're eligible and should get it before. A high-dose flu vaccine is conditionally recommended if available to you over the normal dose flu vaccine. Definitely staying up to date with your COVID shots is important, and you should get your Shingrix as well, your shingles shot. You don't have to wait until age 50 if you're immunocompromised, okay? Cardiovascular health is also of utmost importance. I think you were telling me earlier, Suzanne, you guys are doing a talk at CCF on cardiovascular health in a few weeks. The reason that it's so important is that one of the main causes of mortality in patients with rheumatologic disease is still, at the end of the day, heart attack, which is granted one of the main causes of mortality in everybody, but it's even a higher risk in patients with lupus. Most people know that obesity, hypertension, diabetes are all risk factors for getting a heart attack, but actually lupus in and of itself is an independent risk factor for coronary artery disease. So it's really of utmost importance that the patient, tries to work on the modifiable cardiovascular risk factors they can work on, such as cholesterol, hypertension, obesity, and really, follow this closely with their primary care doctor. And most primary care doctors probably already know this, but don't feel afraid to remind them, if in fact they don't, that lupus, just like diabetes, is an independent risk factor for coronary artery disease. Bone health is something that's also very important to think about. So like we talked about, patients with kidney disease over time can get weaker bones, but a lot of our lupus patients also end up with weak bones due to just cumulative use of steroid. Steroids are bad for the bones, but often needed to control lupus. And so we really want patients to, if they're on steroids, buy some calcium and vitamin D and take that over the counter, and make sure that your primary care doctor screens you for osteoporosis with a bone density scan. And, I think a lot of rheumatologists, probably sometimes myself included, we're so busy focusing on stabilizing the patient that sometimes we ourselves can be bad about forgetting to work on this preventable stuff. So, as the patient, please feel empowered to remind your doctor to think about your bones and just say, I know I'm on steroids. I know that's bad for my bones. What should I be doing to work on that? Okay. And I also want to bring up cervical cancer screening because that, for various reasons, is not something that's spoken about enough, both in lupus patients and in just regular people. So cervical cancer is caused by human papillomavirus, or HPV, and patients with lupus and patients who are immunocompromised are, more predisposed to infection, including HPV, which makes them more prone to cervical cancer. So if you're between the ages of 26 and 45, which is, last I checked, at least the ages the vaccine is approved for, please go ahead and get vaccinated. I think the vaccination came out when I was, I don't know, in college or something like that. So, you may not have received it. So if you haven't, and if you're in that age group, please get it. And please make sure that you're staying on top of your pap smears and getting screened for cervical cancer with your either primary care doctor or OB-GYN. Okay. So how do we monitor lupus patients, or lupus nephritis patients rather? So like I alluded to earlier, we have to keep blood pressure under control. So at every single visit, blood pressure is checked. We monitor labs as well. We're looking at hemoglobin, we're looking at basic blood cell counts, we're looking at kidney function, we're looking at protein levels, and at every visit, we also are looking at the urine. We're looking for signs of lupus nephritis in the urine. So typically we look for blood and protein. A urinalysis should really be done at every visit because before you're going to see any evidence of kidney disease in the blood work, you're going to see it in the urine. And like we discussed, we want to catch it early. We ideally want to catch it before the blood work even becomes abnormal. And this may be obvious, but when you do get your urine, make sure you go during a time you're not menstruating, because that would make the urinalysis, uninterpretable, because for obvious reasons, there will be a lot of blood and protein in your urine for anybody if they submit their sample during menstruation. Okay. If there's one thing that I would like patients to take away from this presentation, it would be that lupus nephritis is complicated, and it really does require a multidisciplinary team. You should follow regularly with a rheumatologist, a nephrologist, and a primary care doctor. It's a complex disease. There are a lot of things to think about, and I think that my patients who do the best are patients who have good care with me, as well as nephrology and their primary. Okay. So the prognosis for lupus nephritis is getting better and really not that bad. So in 1950, we didn't have great drugs. So the 5-year survival rate was close to 0%. It's been improving since then, and in 2017, the most recent percentage that I could find was there was a 96% kidney survival rate. And since 2017, in 2020 and 2021, we have even more great therapies. So, the future is definitely bright. Okay. So in summary, we discussed lupus nephritis today. We discussed the symptoms that patients may suffer from. We discussed that early diagnosis and aggressive treatment is very important to prevent the long-term complications. We discussed that it's really a multidisciplinary it really requires multidisciplinary care and a lot of care coordination between the patient, their primary care doctor, a rheumatologist, and a nephrologist. And overall, prognosis for the disease has dramatically improved and, continues to get better. Suzanne will probably know more about this than I will, but here are just some resources for, patients with lupus to reach out to people who also suffer from the disease. And that concludes my presentation.
Wow. Questions?
I have a question
Of
about
course.
calcium.
Okay.
I have a history of kidney stones.
Yes.
So I try not to take a lot of vitamins and calcium, supplement it with other real things like milk and yogurt. But is there a type of calcium that wouldn't affect me as much in a pill? Anything new?
Yeah, that's a great question. So the National Osteoporosis Foundation recommends 1,200 milligrams of calcium a day. If you have a history of calcium kidney stones, we typically recommend that you just try to get that in diet. Now, if you eat terribly and just ate McDonald's every day, you still probably would get around 600 milligrams of calcium a day, not thinking about your diet at all. So I typically tell patients, if you don't want to think about your diet, just take one 500 to 600 milligram calcium tablet a day, combined with eating whatever you want. Or if you want, just be more cognizant of the calcium you're taking through normal food and eat a higher calcium diet. So for you, since you have a history of kidney stones, I would say just be a little bit more cognizant. And if you try to get like 1,200 milligrams of calcium a day, that's fine. You don't need more. Like taking surplus calcium isn't going to help your bones.
Okay,
Yeah.
thank you.
Anybody else? I always have questions, so I hate to take up time, but I'm going to take up
Yeah,
some
of course.
time. Okay. So first of all, I want you all to know that the kidneys are a very, very important part of this journey. Okay. And most of our constituents that don't do well, it's because of the kidneys. So my question to you is, how do we know we have it? What makes us take that step? Other than going to the doctor, getting our test, because there's regular aches and pains. We never know what's lupus or what's something
Of
else.
course, yeah.
So what can we look for, or what should we be aware of? Is it a taste in our mouth? Is it a pain in our back?
Mhm.
Are there any symptoms that we should be privy to help us know when to ask for help?
Yeah, that's such a fantastic and difficult and complicated question. So I think that uh, first things first, I think every person ultimately knows their body best. So if you're someone who's just always suffered from pain since you were a child for a variety of reasons, that probably doesn't mean you have lupus. But if you're noticing a change in your symptoms and things are feeling different, like, maybe a patient has always felt pain their entire life, but now they're waking up and for some reason they're feeling more pain in the mornings and they're feeling more swelling in their joints, I think that's a reason to tell your doctor, start with primary, that things have changed, my joint pain is changing. Why do you think that is? Lupus is such a complicated disease. It's hard to it's hard for a patient, I think, to know they have lupus. I think the best thing for them to do is to, if something changes, let their primary care doctor know. Of course, there are, certain criteria for lupus. So things like malar rash, so the pictures that Dr. Warren showed you guys previously, things like arthritis, but it's not normal arthritis. It's more like swollen joints in the morning. Things like certain lab abnormalities, sometimes hypertension. These are all things that can be associated with lupus, but I think it's difficult for even a primary care doctor to diagnose, let alone a patient.
But when it comes to lupus nephritis,
Yes.
Would we have blood in our urine? Would we have pain in our back? Would we have just swelling of our feet? So it's kind of like a silent attack.
Yeah, that's also a completely fantastic question. Ideally, that, as soon as lupus is diagnosed, they're also monitoring you for nephritis. So for all of my lupus patients, I always check their urine. It's a cheap test, it's an easy test. You really want to catch nephritis before you get symptoms of nephritis. So if I catch someone who already has new onset uncontrolled hypertension and a lot of swelling in their legs, some damage has probably already been done. So as soon as you're diagnosed with lupus, your urine should be monitored. Maybe every few months in the beginning. If you're stable for a while, maybe space it out.
Well, I know for those of us that see rheumatologists every quarter or something, 3 months or 4 months, usually we get the cup. Okay, but if you're seeing a primary care doctor, I don't know if that's the case. So you need to ask. All right. But my other question is, and you said this, you were showing the picture of the biopsy.
Yeah.
Ouch. Okay. Then you said that people with lupus could have kidney problems, but not be nephritis.
Oh, absolutely.
Really?
Yeah. So, I mean, if you
What's
think
the difference?
So if you think about it, a large portion of America has kidney disease. Most of them do not have kidney disease due to lupus because lupus is relatively rare. So kidney disease can occur for a variety of other reasons. It can be due to too much NSAIDs, too much ibuprofen. As you can imagine, a lot of our lupus patients may have been on too much ibuprofen for years before they got a diagnosis. It can also be due to hypertension. So, one of my patients who I thought maybe had lupus nephritis, the biopsy just showed she had hypertensive kidney disease, but it was not due to the lupus in and of itself. So I'm not going to treat that with immunosuppression. It can be due to diabetes. There are various reasons patients can have kidney disease and it not be due to lupus.
That's interesting. I find that to be very interesting. My my uncle had lupus nephritis.
Mhm.
He did have a kidney transplant, and he lived, many, many years
Mhm.
beyond that.
Yeah.
Okay. I have kidney disease.
Mhm.
You have kidney disease. And it's like, well, I'm trying to figure out, well, what's the difference here?
Mhm.
Okay, so clearly there's a difference.
Oh, absolutely.
Okay,
Yeah.
and I'm going to warn you of the ibuprofen and the over-the-counter drug. Do not self-medicate obsessively, because some of these over-the-counter can cause you other problems. Make sure your doctor is aware of what you're taking over-the-counter.
Mhm.
Anybody else? There you go. Take the bashful out of all of them.
So when I got diagnosed with lupus nephritis, it straight up was like, I think they said it was like level 3. It was confusing. They couldn't figure out what level exactly
Sure.
it was. But now I finally figured out it's right in between the 3 and the 4.
Okay.
Other than the treatments and the medications, like rituximab, all that fun stuff. Is there anything else I can do to make sure that I'm not going to go any higher on the stages of, like the 4, the 5, the 6?
So they said you were, remind me what stage did they say
Is
you
it
were?
right in between 3 and 4?
Okay. So, it's when you think about stages, like, for cancer, higher stages is worse, and intuitively, it really would make sense if a stage 4 was worse than a stage 3 and a stage 5 was worse than a stage 4. For whatever reason, the numbers don't add up like that in lupus. 4 is usually considered the worst. 3 is, better than 4, but 5 is probably better than 4 too. So progressing in the stages, it doesn't go numerically. Um, and they are treated a little bit differently. So probably, with your rheumatologist and nephrologist and primary care doctor, and make sure that you're controlling your hypertension, make sure that you're not taking NSAIDs unless it's been okayed by your nephrologist. And NSAIDs meaning ibuprofen, and that's pretty much like all you can do. But if you were even doing all of that to change classes, we call it class switching. It wouldn't be anything that you've done or anything that your rheumatologist has done. For some reason, sometimes people switch, and we're not entirely sure why. Yeah. So when they said you were between a class 3 and 4, probably part of your biopsy looked like 3, but part of it looked like 4. But the treatment is, pretty equivalent. So they're probably just, treating you for lupus nephritis. Yeah.
How high does this go?
So if you get to class 6, that's considered like end stage, meaning needing transplant. So we typically, won't treat you with 6 because the damage is done. There's no point in trying to reverse it. We just try to get you to transplant. Stage 1, kind of interestingly, a lot of patients might have stage 1 and we'd never even know because it's so minor that even your urine will look normal, and you really shouldn't treat stage 1. So I don't know how many patients even have stage 1 and we never know. Stage 2 is kind of like the most minor, or really it's not called stages, it's called classes. Class 2 is, the most minor, and we might find it on biopsy, but it doesn't necessitate specific nephritis treatment. Classes 3, 4, and 5 are the ones that necessitate specific treatment. And as a general rule, 4 tends to be the most severe, and you can have a combination of 3 and 4 or 4 and 5. So it sounds like you have a combination. Yeah.
There's one more.
What was the importance of, you mentioned cholesterol.
Mhm.
How can you explain how the importance of controlling cholesterol affects your kidneys?
Yeah, that's a great question. So a couple of reasons. One is that lupus in and of itself is, a very high risk. Patients are very high risk for coronary artery disease. So controlling cholesterol is, helping make sure that you don't get heart disease. And 2, this is more rare but can happen. Sometimes cholesterol can accumulate in the, vasculature or arteries of the arteries of the kidney, and that can also worsen kidney disease.
This is just a comment, though.
Of
When I
course.
first was diagnosed with lupus, of course, my count was extremely high.
Mm-hmm.
I would just go to the doctor and think, well, I'm there. He knows I have lupus. He knows everything. Well, of course, they don't, because you have to tell them where it hurts or what hurts.
Yeah.
But what I didn't realize is that if your lupus is very active, it can affect any part of your body.
Mm-hmm.
Could affect. So then, it makes you more cognizant of, okay, I have a flare up, so I should be watching for anything to happen
Mm-hmm.
and report that to my doctor instead of just saying, oh, I don't feel good.
Yeah, no, it's definitely such a protein disease, and that's why it's really important for patients to, even if they have a good doctor, be their own advocate because, doctors may know more about lupus, but you know more about your lupus than they do.
Well, that's a lot.
Mm-hmm.
Very good.
Thank you.
Thank you. Thank you so much. For those that don't know Brenda, did you tell them who you